Thank you, Meg. We learned a lot on the role of patient data for treatment value, unmet needs, and also disease burden. And later, we'd love to learn more on a few cases on how to guide real evidence to engage both patient, public, and private payers. But before that, I want to zoom out a little bit for just a few minutes to share with you a framework on leveraging real evidence to address unmet needs in the patient journey. I also will highlight where the access and the financing bits gonna fit. I think this is a very inspirational story of the patient organizations, specifically in rare disease area in China. So here are just some statistics on the patient groups and how they are leveraging real evidence in China. You can see there are around 130 rare disease patient groups in China. And the rate of leveraging patient registry is actually quite high. Over 75% of them actually are proactively doing patient registry. And then there are also around 37 patient groups that are systematically doing survey in collecting primary data, and they all work with various partners. But certainly there's still a lot of variations and the different purpose that they are using different methods in collecting data, and sort of more systematic continuous capacity development can be very valuable. So with that, we are starting to develop a framework on how to leverage different kind of patient data and tools in collecting real evidence that be able to really support patients through the whole life journey of the whole life cycle of management of the patients with rare diseases. So here on this slide, you can see we use two different colors to separate the patient registry data and patient survey data. And then we have mapped out the whole journey, the life cycle of management of patients, mainly divided to like before the medical treatments, which including screening and also new drug development, and then bring the treatments to people, especially the approval of new treatments, access, and improving affordability of those treatments. And then after the medical treatments, there are also additional elements like the social services advocacy and also continuous monitoring of the adverse effects. So here you can see to serve all these different purposes along the life cycle, there are value of leveraging real world data, and also specific data and specific forms of data that can be collected to be able to serve the purpose. Here you can also see there are in the center on how to leveraging real evidence, especially through survey data, in improving access and affordability for reimbursement of those innovative treatments. So I will put my email here. So this is a very complex framework, and we have much more data that we'd love to share with you and more resources on this as well. So we are also actively developing a website as a toolkit to empower patient groups to be able to navigate through this framework, and also provide toolkits for them to embark their journey in starting collecting their data. And next, I would like to invite Zhengchen Liu from New Sunshine Foundation and Prof. Sharon Hsiao from National Taiwan University. She joined us for fireside chat and continue our discussion on real evidence collection. Let's welcome Zhengchen and Sharon. So first, I want to hear from Zhengchen your case for patient advocacy group, skill building evidence to drive reimbursement, please.
Okay, thank you, Chang. Thank you, everyone. I'm Zhengchen Liu from New Sunshine Charity Foundation. And as a charity foundation, we provided many financial aids for patients. For example, and many of our projects are inclusive economic funding projects. For example, in Qinghai province, we provide financial aid for all children with leukemia, as well as children with solid tumors. Now we are also expanding to many other diseases. So when we do these financial aid projects, we find out we are also a payer, and the rule is similar to the National Health Security Agency in China, who decides NRDL, or National Reimbursement Drug List. So we find out if we can advocate for a specific innovative drug uploading into the NRDL, the patient's disease burden will decrease dramatically, maybe hundreds of millions of Chinese yuan all over China of the patient economic disease burden will be decreased. So we began to learn and understand how is the health authority make decision of the NRDL. We find out the HTA or health technology assessment is a key decision-making tool. And we also find out the dynamic adjustment of the NRDL of China is different with that of the NICE or NHS in United Kingdoms. We find out that in national NRDL decision making, the timing of the HTA review is much less than that of NICE. So based on the differences, we developed a HTA process of charity foundation as a pair. We developed this process firstly for ourselves, and we implemented it in areas where we have inclusive funding projects. And after and we so far we have made the evaluation of an innovative drug for hemophilia, and we are doing the HTA for drug for thalassemia now. So the process focus on the following aspects. Firstly, in the small pilot area, our decision making as a payer should be scientific and transparent because we are using the HTA method, and it is a key method for the decision making of NRDL in China and for the NICE in United Kingdoms. And secondly, we submit the results to the National Medical Insurance Administration or National Health Security Agency in China, and we advocate that the evaluated drugs be included or uploading to the national NRDL, National Reimbursement Drug List. And we also, third one, we also advocate for more scientific and transparent processes and patient participation, patient involvement in the whole process. This is a HTA process in charity foundation we developed. First, evaluation, the pharmaceutical companies submit clinical value evaluation and pharmacoeconomic evaluation materials to us. Secondly, we invite a HTA board group. Secondly, we invite a HTA group in public health university or the Department of Health Economics. We invited a group to review the material of the which the pharmaceutical companies submitted. And the third part is appraisal. A diverse committee appraise the HTA reports and make conclusion, recommendation, conditional recommendation, and not recommendation. And last part is pair decisions. We negotiating the price with pharmaceutical companies. This is a process, and we strongly recommended the patient groups should be part of every parts of the HTA process, from the evaluation by the pharmaceutical company, and the second part is the HTA assessment by a HTA group in public health school of the university. And third one is appraisal committee. The patient should be part into the part of the appraisal committee. So besides of the HTA, a patient can also involve in the all patient groups can generate the patient disease burden with collaboration with public schools experts. So the patient disease burden and the HTA process, I think patient can both involve and very actively involve into these processes and to involve into the decision making of the government. Thank you.
Thank you very much, Zhengchen. I think it's fascinating work that you're doing as a private payer, but also very innovative. And I love the fact that you're linking the private payer to advocate for public payment reimbursement as well. So next, I know Sharon, you have been working very closely with Taiwan government on the RWE and health economics. So look forward to sharing on the RWE framework from Taiwan and MES.
Okay, thank you. Thank you for Zhang's very nice introduction, and I'm very happy to join Zhang and Zhengchen today to talk about real-world evidence and health policy shaping. So today I'm going to talk about a very important example in Taiwan. So as on the right-hand side, I'm just want to give you a very quick overview regarding the public health system in Taiwan. As you can see from the figure, Taiwan has a universal mandatory coverage, which is managed by the National Health Insurance Administration, which means approximately 99.9% of the population receive the coverage of national health insurance here in Taiwan. So as a public payer, the NHIA actually face a lot of challenges regarding how they are going to do their decision making. So one of the very important example is the decision regarding whether to reimburse immuno-oncology in 2018. So at that time, as you can see, immuno-oncology has a lot of indications for different kinds of cancer, as you can see from the table on the right-hand side. As it has so many potentials, it also costs a lot to the NHIA, which means a lot of money. But due to a lot of unmet medical need from the patient side, the NHIA decided to reimburse the IO, the immuno-oncology, at the very initial stage. However, the NHIA also set up a patient registry to continue to collect real-world data after these patients receive immuno-oncology to see whether the data in real-world setting is similar to those observed in clinical trials. So as you can see from the right-hand side, according to 1,600 patients' data, we can see the overall response rate is quite different. So these are actually very variable to the public payer to do their future decision making to see whether they are going to continue the reimbursement of immuno-oncology or not. And actually, this data has been publicly available in the following journal, as you can see the citation here. So I think all countries can take this as a very important example to see how patient registry can help to collect real-world evidence and help health policy shaping. Just like Zhang mentioned in his slide, patient registry is very important to collect patient data. So here's one example. So seeing the importance of real-world evidence, the local professional association here in Taiwan, the Taiwan chapter of the International Society of Pharmacoeconomics and Outcome Research Task Force initiated a task force last year to work with UK NICE to do the local adaptation of nice real-world evidence framework in Taiwan. So through different process, right now the framework is under the peer review process. So we also act as the chapter lead. We also work closely with the local HTA body, that is the Center for Drug Evaluation here in Taiwan, to provide local examples regarding how real-world evidence can be used in the decision-making process. So hopefully we will finalize the Taiwan real-world evidence framework in the coming May. And then we will have a series of educational activities and also the panel discussion with different stakeholders to see whether we can locally adapt it, the framework in Taiwan to help to collect more valuable real-world evidence for the payers and also for the private sectors. Of course, patient groups will be very important stakeholders during the review process, as well as the panel discussion. Hopefully, the local adaptation of the nice real-world evidence framework can incorporate more patients' opinions during the process, and then make the patient's opinion to be seen in the real-world evidence framework. Thank you. So I think that's my short share regarding the real-world evidence and health policy shaping in Taiwan. So I will give it back to Chang. Thank you.
Thank you very much, Sharon. It's great to see the systematic development of real-world evidence framework in Taiwan. So I just pose one question to both of you, just from patient groups perspective. What's your recommendation for them to take action and start this journey? What's the first 1 or 2 steps they should take? Maybe start with you, Sharon.
Thank you, John. That is a very good question. So from my point of view, I will suggest the patient group to keep their eye on the current policy, because like I mentioned, like the first example I shared with you, if the patient group can notice that the public payer is going to set up the patient registry, and then they can join at the very beginning, then I think their voices and their opinions will be taken into account during the data collection process. And of course, this is a very important step for patient groups to work with the public sector. Thank you. That's my opinion.
Thank you very much. How about you, Zhengchen?
My suggestions for patient groups is first to reach out to more patients and doctors and to serve for them. For example, to organize patient group meetings and to invite the doctors to give lectures for the patients about the disease and the treatment and so on, to organize more, reach out and organize more patients. And secondly, is to learn more about the government's priority, learn more about how government make decision, what is RWE, what is patient experience data, how to do the report, and how to collaborate with professionals. And the third one is collaboration, to collaborate with health economists in the public health school of medical universities, because in order to advocacy for the policy, we should provide powerful evidence. Patient groups can organize more, maybe 1,000 or 10,000 patients to do the survey, to answer the questionnaires. But the research should be designed and executed by the experts in like health economists or public health experts. This is my 3 recommendations. Thank you.
Thank you very much, Sharon and Zhengchen, for your very insightful sharing. And now I will hand the session back to Julie to continue to the next discussion.
Thank you.